Now we'll move to Dr. Laetsch, who will talk about NTRK fusions in childhood cancer.
Thank you very much for your attention. So I'm a pediatric oncologist at Children's Hospital of Philadelphia and the University of Pennsylvania, and happy to talk about the sort of pediatric aspects of this. Next slide. Here are my disclosures, including that I've consulted for Bayer, which manufactures larotrectinib, and have a research funding for the study of larotrectinib in children. Next slide. So here are some common questions that I get about pediatric cancer that I'm going to try to address with you today in a few minutes, and then be happy to take additional questions later. So these include which childhood cancers have NTRK fusions, who should be tested, what are the treatment options for NTRK fusion cancers, as has been discussed already today, how long should patients be treated with NTRK inhibitors or TRK inhibitors, and what are the side effects of those therapies, and what research is ongoing. Next slide. So this was covered in the last talk nicely, just about the range of cancers that harbor NTRK gene fusions. I think there are some unique aspects about this in children, particularly that there are these cancers where essentially you have to have an NTRK fusion to have the cancer. Those include infantile fibrosarcoma, a rare type of pediatric breast cancer, and a particular type of congenital mesoblasthic nephropathy, a kidney cancer that happens in very young children. But there are other cancers shown here in blue where TRK fusions happen, but they happen at a lower rate. And so most patients with brain tumors or leukemia don't have TRK fusions, but some patients do, and we may have novel treatment options for those patients. And so it's important to think about how we test these different groups of patients. I also think it's important to note in pediatric cancer that there's big groups of cancer where we have never found a TRK fusion so far. And while we can't say that they never occur in these cancers, it seems to be very rare. And these include many of the common pediatric cancers, things like neuroblastoma, Wilms tumor, rhabdomyosarcoma, et cetera. Similarly, most of the common bone cancers don't seem to have TRK fusions either, things like Ewing sarcoma. So it's important for pediatric doctors, pediatric oncologists, to be familiar with which cancers may have TRK fusions and which cancers it's very rare or not reported, so that we can understand which patients need to get tested. Next slide. So, my approach to testing is the following, and really what I recommend is that patients who have one of these characteristic tumors get tested at the time they get diagnosed with cancer. As well as patients who have these other tumors where TRK fusions have been described. And these include other types of sarcomas, as well as gliomas or brain tumors, particularly the high-grade glioma type, which is a more aggressive type of cancer. But I think that everyone deserves to get tested at the time if their cancer comes back, or if they don't respond, the cancer doesn't respond to the standard therapy. And that's partially to identify TRK fusions, but it's partially also because there are a number of other types of genetic alterations that we can also target. And so it's very difficult for myself, even as a TRK fusion expert, to know which patients are going to have a TRK fusion. But I think offering this testing is important to identify the TRK fusions as well as the other alterations that may lead to a different therapy that may help patients. And really, I think the field is moving towards every patient getting tested up front. So how common are these other alterations? This is data that was presented at a number of different meetings recently, but about 50% of kids with cancer have a potentially targetable genetic mutation in their tumor. Many of those, I say potentially targetable because many of those we don't yet know if targeting those mutations work. And the number of patients who have changes like NTRK fusions where we know that targeting the mutation will work is much smaller, and it's probably less than 5% of patients. But it's impossible to predict which patients will benefit, and these therapies can have really life-changing implications for patients and their families. And so I think despite the fact that right now it's a small proportion of children where sequencing clearly changes the prognosis of their cancer, it's still very important to do to offer everyone this possibility. Next slide. So this slide just talks about the range of different mutations that we've seen. If you click advance, I think an arrow will show up. Yep. The red arrow here is highlighting NTRK, which is what we're talking about today, but I'm also highlighting green arrows on other mutations that are targetable and for which therapies have recently shown to be very effective in pediatric cancer. And so the point here is that it's not just NTRK. While we're talking about that today, there are many other mutations, and so patients deserve to get sequencing to identify NTRK as well as these other alterations that may benefit them. Next slide. So what are the options for treatment for patients with NTRK fusion cancers? And really, the optimal therapy depends on the tumor type and location. Some patients, even with these NTRK fusion cancers, can be cured with surgery alone and don't need any systemic therapy. And those patients shouldn't get a TRK inhibitor. They shouldn't get any chemotherapy. They should have what can be sometimes be not a surgery that doesn't lead to long-term side effects and be cured. And so that would be the standard therapy. But for others, we're still learning about the optimal timing of when to use a TRK inhibitor versus when to use chemotherapy. And I'll talk a little bit about some research that's ongoing trying to evaluate that question. There are a number of TRK inhibitors, both in development and that are FDA approved. For children, laetsch is the only FDA approved TRK inhibitor that's available for children of any age. And that's because it comes as a liquid, so it's available to treat children as young as shortly after birth. Entrectinib is also FDA approved for children, but only those over 12 years of age. And that's because of, partially because of the formulation, that there's not a liquid formulation available for young children. Next slide. And as has been discussed, this is a slide that's showing a number of patients, children treated on clinical trials of laetsch and showing what happened with their tumors. And so each of these bars is an individual patient's tumor. And when the bar is below the line there that's labeled 0, that means the tumor shrunk. And so as you can see here, this is the most recent data from the pediatric clinical trial of laetsch. And of the 59 patients that were treated, 92% of them had tumors that shrunk significantly enough that we called it an objective response. So essentially, almost all of the patients have their tumors shrink, and some of them, those labeled negative 100%, are tumors that shrank all the way down to a complete response to no visible tumor. And we saw this across patients with infantile fibrosarcoma, which is the dark blue line, as well as other soft tissue sarcomas, thyroid cancer, and congenital mesoblastic nephroma. Next slide. Entrectinib has also shown promise in pediatric patients with TRK fusion solid tumors. Here, the TRK fusion patients are highlighted in green. And again, you can see in the majority of patients, 6 out of 7 of the patients with solid tumors outside the CNS, there were responses to laetsch, so the tumor shrunk significantly again. I'm sorry, to entrectinib, so the tumor shrunk significantly again. Next slide. So as I mentioned, one of the most common questions I get asked is how long should children be treated with TRK inhibitors? Next slide. And I don't have a great answer to that question. This is data from those clinical trials of laetsch that shows what we call the duration-free response and progression, duration of response and progression-free survival. So the duration of response tells you how long patients' tumors continue to shrink once they start to shrink on therapy, and the progression-free survival tells you how long patients' tumors have shrunk before they start to grow again. And in both cases, more than half of the patients' tumors are still responding to therapy. But these are ongoing clinical trials, and so we're still trying to learn about how long patients need to be treated and whether or not this therapy can be curative by itself, meaning you can eventually stop it without having the tumor recur, or whether or not it needs to be continued indefinitely. We're also trying to understand whether the therapy can be used before surgery, for example, to make surgery easier and have less side effects, and then stop therapy after surgery? So these are all sort of ongoing questions, and happy to talk about them, but I don't have complete answers at this point. This is unfortunately one of those things we're still learning about. Next slide. And this is an example of a patient where larotrectinib was able to facilitate surgery. This is the patient that I treated, where their tumor shrunk significantly. You can see the baseline picture and after 4 cycles pictures. The big white blob on the screen is the tumor in this patient's arm. And it shrunk significantly with therapy, and then the patient was able to undergo surgical resection and has stopped larotrectinib and remains off therapy and doing well. There have been a few other patients for whom this has been reported, 5 in the literature so far, and 3 of them have been able to discontinue larotrectinib. So we're still learning. There's some promise here, but we don't have enough data to say definitively when this is effective. Next slide. There are a couple of ongoing research studies, and they're helping to try to answer these questions. So one of them is through the Children's Oncology Group, and the study is called ADVL 1823, but really the goal of this study is to give children with newly diagnosed NTRK fusion cancers treatment with larotrectinib without giving them chemotherapy first. And so the goal is to try to see if we can spare the need for chemotherapy and evaluate how long this therapy needs to be continued, and also to evaluate some of the side effects of larotrectinib, particularly whether or not there's any impact on cognitive development because of the role of the TRK proteins in the nervous system. There's also an ongoing clinical trial of entrectinib called Star Trek Next Generation, or Star Trek NG. The people that thought of that spent a lot of time coming up with this cool acronym. And then there are still other studies of larotrectinib that are ongoing, including the trial that I mentioned for which those patients were treated, called SCOUT, and what's called a post-marketing study where patients who are getting treated with larotrectinib, now that it's approved in the United States, are being followed to gather additional safety and efficacy data, particularly data on development of children. Next slide. There are also, as was mentioned, next generation TRK inhibitors, and the 2 of these that are worth mentioning are repotrectinib and selatrectinib, and they're both have ongoing pediatric clinical trials, and they're both available as a liquid to enable dosing of young children. And these may block some of the resistance that can occur on the first generation drugs, and so maybe options if the first generation drugs stop working, or perhaps may eventually replace the first generation drugs if they're found to be safe and effective. Next slide. So I want to thank everyone who did all this research that I'm getting to present to you today, both the physicians and all of the staff at all the centers, but most importantly, all of the patients and the families who enrolled in these clinical trials when we didn't know as much about TRK fusions and when we didn't know whether these therapies would be safe or effective. Thank you.